Hi students, and welcome to Adult Health Now on Module 6, moving right along. You for showing up and coming here to listen to a lecture. It's so helpful for the auditory learners. So what are we going to talk about in Module 6? We're going to talk about organ donation and organ transplant, specifically lung, kidney, heart, and liver. So first let's talk about organ donation. So I'm going to play a story here.
My daughter's name was Ayana, and she was killed on December the 5th of 2021. She had the biggest eyes. They were just some big little bug eyes. And she always was smiling and getting into a bunch of stuff. I got a phone call that someone had been shot, and I looked at my phone to see the news break, and I realized that it looks like my daughter Ayana's car. So I called my son. He said, "Mom, I believe it's her."
But after I got off the phone with her, I just fell to the ground. And seeing my kids say, "Hey, Dad, what's wrong?"
After realizing that my daughter wasn't going to pull through, I talked to my oldest daughter, and she said, "Mom, we should consider donating some organs because it can save lives." And at first, initially, I wasn't on board because I didn't know very much about organ donations, and I just said no. Because I believe in the African American community, I don't believe we know very much about organ donations. I've always heard about it, but I really didn't know any depth because I never had anybody actually come and ask me about organ donations or do any research on organ donations. Once speaking with the staff, it just made me feel like this is what I need to do. And I'm doing a good thing, and I'm saving someone else's life.
Being honest with you, I was against it at first. Never even considered it, donating my organs. And even that when my son passed, I wish I would have done it. I've never seen something so beautiful in my life. Even though it was a tragedy, something beautiful came out of it.
I'm really glad my mom did do it. We wouldn't even have this opportunity to be all sitting here at this table discussing it, talking about it. There's been a lot of good things that came out.
We all were impacted by the honor roll. From beginning to end, you couldn't ask for a better honor.
Honestly, just felt a lot of love. And a little hope.
Once she got wheeled on through those double doors, I was like, now let's go save other lives. Because her life is gone here, but let's go save others. And I believe Anna made a difference amongst our community by sharing her story. It made a difference. I was one of those same people that was on the outside looking in. And look at me now. I'm speaking loud and proud about something that I strongly believe in now. Ayana was a good kid. I believe she had a big heart. She would have wanted her organs donated, and I don't regret a thing.
Okay, so organ donation, let's talk about it. When I was a brand new nurse, this was 1994, I worked in a trauma surgical neuro ICU in Illinois at Christ Hospital and Medical Center. It's part of Advocate Health Systems, and we were the #1 center in the state for organ donation. We just had a ton, and so we would get these letters all the time. Describing, the skin went here, the cornea went here, the lungs went here, and it was really rewarding to us as nurses because it's a really difficult conversation to have. And it's almost like, you would rather not have the conversation with the family to ask them if they want to donate organs. So it encouraged us to have those conversations. Anyway, so let's talk about this. So the demand for organs is tremendous. There's a lot of, it's funny, I was just watching, I don't know if it was 2020 or one of those the other night, about the underground system for kidneys and things. That's pretty scary. But anyway, in an effort to meet this demand, many states have donor registry programs. So more than 78,000 people in the United States are awaiting transplants. There are many challenges. There has to be immune system management. So although there's immune system suppression necessary for the survival of the transplanted graft, it has improved over the years. It still is not without complications. So infection secondary to immune suppressant medication, an infection as a result of the immunosuppressive medication therapy remains the major cause of death in recipients of organ transplants. So a single donor, so utilization of all solid organs from a single donor provides 58.5 additional life years spread over the 6 organ transplant recipients. So that's pretty impressive. So the OPO is the Organ Procurement, try to say that 10 times quick, procurement organization. So this is, it's the transplant process that coordinates, by an organ procurement organization. It consists of multi-professional teams, handle the donor management, the list of potential recipients, and notification of available organs, because that's super important too. The donation services, and then bereavement care to the families of the individuals that are donating. So the transplant team, there's a surgeon, physician, social workers, pharmacists, transplant coordinators, acute care providers, and in the Center for Medicare and Medicaid Services, there are conditions for participation. So because there's a shortage, there is an effort to increase the available organ pool. So in 1998, the CMS implemented, conditions for participation for transplantations. So hospitals that receive Medicare reimbursement must notify the local OPO of cases of impending death in order to continue to receive Medicare reimbursement. Because we need early identification of potential donors, that involves the acute care facilities. There are mechanisms of death in potential organ donors, such as asphyxiation, blunt injury, cardiovascular event, drowning, drug intoxication, electrocution, gunshot wounds, intracranial hemorrhage or stroke, seizure, stab wound. So all these things could be things that would have a patient that could donate. So liver donor. Although not possible for all organ types, living related donors do provide the best possible outcomes first and foremost as the procedure becomes an elective procedure, because you don't need your entire liver. Excuse me. So long-term outcomes are better when the donor source is a living relative. So to be considered a living donor, there are certain criteria, of course. You have to be in overall good health. I mean, you don't want to donate part of your liver if your liver isn't good. You cannot have diabetes, and diabetes is huge. So many people have diabetes. You can't have cancer, heart disease, kidney disease. You have to have a compatible blood type, and you have to have a good BMI. So in addition, BMI is becoming a criteria to ensure the best outcomes for the donor. For patients with a potential donor that is not of a compatible type, then a paired donation is an option. So brain death. Brain death is, a neurologist has to decide that somebody has brain death, and so it is defined as absent cerebral and brain stem functions with a non-survivable head injury. So first of all, there have to be prerequisites for the clinical evaluation, and then We have the neurological assessment, which is the clinical eval, neurodiagnostic testing, including an electrocephalogram, cerebral angiography, or radionuclide cerebral perfusion scan. We need to identify potential confounding factors, such as, family members regarding status of brain death testing. So hypothermia, high dose central nervous system depressants, massive drug or toxin ingestion. And then these conditions must be reversed prior to brain death testing. We need to document the brain death, and then there are federal and state laws that require physicians to notify the OPO following determination of brain death. So what about donation after cardiac death? So these criteria were established in 2007. So no recovery from illness expected. It does not meet the brain death criteria. It is dependent on life-sustaining measures. So the donation process occurs within a very close proximity to the operating room. So the organ procurement follows the pronouncement of death and usually takes 2 to 5 minutes. Like lickety-split, we got to get this done. You can't sit there and think about it. So many hospitals have clinical criteria or triggers to ensure the appropriate referral of potential organs. And such clinical factors might include the Glasgow-Coma scale, which you're all familiar with. It has to be 5, less than 5, or a severe stroke or brain trauma. It has to be a decrease in loss of one or more brain stem reflexes. Impending withdrawal of mechanical ventilation for a dying patient is also an appropriate trigger for an OPO referral associated with a non-survivable head injury. So how do we manage this organ donation? So we want to manage, we need to maintain hemodynamic stability and normal laboratory parameters. That can be one of the big deals. I remember even this from years ago because it was such a big deal. Like, let's say you talk to a family and they say, okay, you can donate the organs. And then you call the OPO and they're trying to figure out where the organs are going to go. I mean, it's usually like, okay, this one goes, they have it down, right? Of course. And so they look at the blood type, they look at who gets it. People are notified, guess what? You're getting an organ, etc. So you hope that the patient stays okay while you're doing all that. And so it's a super big deal that you have to keep that patient stable, because God forbid you have told this one they're getting heart, this one they're getting a lung, this one they're getting cornea, skin, etc., and then the patient passes. And before you can make sure everything is the way it needs to be to actually donate organs. So there has to be a lot of collaboration between the OPO and physician. There has to be a consent, obviously, for donation. There's the organ recovery organization, and so that is dependent on the relationship between acute care staff and family. So care of the family. Of course, we want to encourage them to ask questions. We're going to have family meetings. We're going to facilitate visitation and communicate honestly about their prognosis. We're going to start the discussion early about the patient's grave condition and make sure that they understand about organ donation, because you can't wait till the very last minute to start having those conversations, even though they're very difficult to have ahead of time. So discuss their fears. So candidate selection. So evaluation of candidates for transplantation is a multidisciplinary process that is carried out well before entry. We want pre-transplant, we want a transplant coordinator. There'll be education of potential candidates that undergo extensive education about the transplant process, follow-up, and maintenance. Patients are evaluated by both physicians and surgeons to determine eligibility. There are social workers that all they do is transplant. So they evaluate a candidate's social support system. It's critical because not only is it getting the family to donate the organs, but once they're donated, that family has to be on board with everything you have to do once you've received a donated organ, with all the medication requirements and everything else to make sure it is a successful transplant. You don't want to waste an organ on someone who's not going to take care of it, essentially. So organ transplant. We have another movie.
I think it was my dad who answered the phone. We were sitting in the living room, like literally right where we are right now. And we were just like by the fireplace because it was like cold. It was February. My dad like put the phone down and looked at me and he's like, "Go get your transplant bag. Like we're leaving like right now. They have a heart available for you." My whole process of getting a transplant was a little bit complicated and it's taken up a big portion of my life so far. So when I was 8 years old, I was diagnosed with dilated cardiomyopathy. And that really took a toll on me because my whole life turned upside down and I wasn't able to do any of the things that I enjoyed. I didn't meet anyone else like me or with, similar conditions as me. I learned to adapt, I found different interests and, sort of figuring out what to do next. And I was stable for about 4 years. But then in 7th grade, everything started to deteriorate really quickly. I was not able to walk around the house, much less go up and down stairs, go to school. And I remember really distinctly one day, I woke up and I physically couldn't breathe. And so we immediately went, to the emergency room and they, saw that my heart was getting a lot worse and, it was time for a transplant. And I always knew at some point, they did talk about needing a heart transplant in the future. But by the future, I thought they meant maybe when I'm 20 or something, much later, not when I'm 12. And so it really hit me that this is really happening right now. I remember my parents were by my bedside and we all just sort of looked at each other we're here, this is the last resort. I really thought genuinely that I would die before I would even start 9th grade. I was 60 pounds, very underweight. They were okay, we need to put a feeding tube into you because you're not getting enough food and you need to be a certain level of healthy in order to have a successful transplant. And I was just crying on the way home. I was oh my God, this is just getting worse and worse. How can this get any more worse? And literally 10 minutes later, they called and they said, "Megan, we have a heart available for you." I like to think of my feelings as colors. I feel that helps me express myself more. I would say the 4 years where I was stable was the colored gray. It was just very mellow, but also bleh. And then the 4 months I was on the transplant wait list was a dark void of space. It was just pure darkness, nothing even remotely happy. It was just terrible. And from that feeling of a dark void of space, the feeling I was feeling before, it suddenly turned into sunshine. Getting that call was a ray of sunshine in such a dark time. Immediately, all my tears stopped and I just smiled the biggest smile of my life. I don't think I've ever smiled that much ever. It brought color back into my life and I'm alive because someone said yes to be a donor. My first year after transplant, I was mainly focused on recovery and transitioning back to normal. And so in 2017, which is roughly about a year after my transplant, and also when I started high school, yay, I realized that there were no community-based organ donation advocacy groups in my area. And so I was okay, you know what? I'm gonna start my own because this needs to happen. This is so important. And so in 9th grade in 2017, I started Amador Valley's very first Pink Dot Club. And we're also the first Pink Dot Club in the entire Tri-Valley area. And we really focused on educating students because, students are getting their driver's licenses, they're, learning to make decisions on their own about themselves, and people will talk about it with their parents afterward during dinner. And I actually got emails from parents saying hey, my kid talked about this with me during dinner, and it really was a awesome conversation. And during this time also I was working as a Donate Life ambassador with Donor Network West separately. And so I was speaking at various, events in various high schools. I've spoken at my own high school about organ donation in my story, and it's a lot of fun. It's my favorite thing. If my donor were here, the one thing I would say is not just thank you, but I hope that I'm showing you that by giving me the gift of life, I am making use of it. I'm trying to do as much as I can all the time, every time, and live a fulfilling life. I want to show them and the donor family themselves I'm doing everything I can to do good in this world. There are many different ways you can register to be an organ donor. You can do it through the health app on your phone. You can do it at the DMV when you get your driver's license or your ID card. You can do it online at donornetworkwest.org. I am living proof that this is a really important topic and it really does help save lives. And it's not some distant thing that you see in TV shows, all dramatic. It is something that affects real people in real life, and I would really want to showcase that, by registering, you are saving a life. Like, this is important, you're doing it. Hi, my name is Megan Mehta, and I'm a heart transplant recipient.
Pretty great. So, what people don't think about too is like burn centers take people's skin. So there's just so much that you can do. So I'm absolutely an organ donor. I'm not telling you what to do, but I tell my husband, it's not going to do me any good where I'm going. So give it to someone who it can do them some good. So organ transplant. So the lung, so candidate criteria would be failed medical and surgical therapies, expected survival less than 24 months. So there's a lung allocation score, and that estimates the chance of first-year survival because the number of lungs available for transplant is so limited that there's a lung allocation score that's used to determine, if the recipient can have it or not. So the candidates with a higher LAS score have higher priorities. Lungs harvested from children or adolescents are offered to children. So the donor criteria, they have to be younger than 55, fewer than 20-pack years of smoking history less than 20-pack years, a clear chest x-ray, PaO2 greater than 300 on 100% oxygen, no history of significant lung disease, infection, aspiration, chest trauma, no organisms on the donor gram stain, normal findings on a bronchoscopy, and then post-operative care and monitoring, respiratory status, hemodynamic, fluid, electrolytes, pain, early ambulation, and they're going to have triple therapy with immunosuppressants. So the kidney, the criteria, dialysis dependent, GFR less than 20, the point system ranks candidates, and so there's ABO typing, time on the wait list, and histocompatibility. Because the time on the wait list probably has to do with how long they have left that dialysis will work. The donor criteria, either living or deceased, paired exchange, because, some people donate one of their kidneys. Post-operative care and monitoring would be their respiratory status, hemodynamic, fluid, electrolytes, weight, additional care concerns. So a kidney received from a deceased donor may take time to begin to fully function. Once the kidney starts to function, they might have polyuria, anuria. Because of the extreme diuresis that can result, fluid replacement therapy is a priority. Dialysis might be necessary during that post-op period, and it's not necessarily a sign that it's rejected. It's just that there's this delayed renal function that happens because of acute tubular necrosis, which can result from prolonged cold time outside the body. So immunosuppressive therapy can vary. However, the majority of them take 3 types of medications, triple therapy. Heart. So candidate criteria, someone has to be in advanced heart failure that's unresponsive to medical therapy. So status 1A is most urgent, then there's status 1B, and then status 2 is least urgent. So for a donor, they need to be, they may be over the age of 55, CAD history, structural abnormalities, left ventricular function, and then post-operatively it's going to be respiratory status. Dysrhythmias are not uncommon due to the warm and cold ischemia times. There might be a decrease in cardiac output or stroke volume, so they might need some supportive therapy. We want to maintain their hemodynamic status. The chest cavity might remain open. They might have a chest tube, and they're also going to have triple therapy immunosuppressants. And those are for the rest of their life. It's not a 2-week antibiotic, so that's why it's such a big deal to discuss that. Liver. So the candidate criteria, it is based on a number of things measuring the severity. The model for end-stage liver disease, looking at serum creatinine, INR, and serum bili. For the donor criteria, it depends on their blood type and their body size. So post-operative, same. Respiratory, hemodynamics, monitor for bleeding, glycemic management. They may have a T-tube, and it's the same triple therapy for immunosuppressants. So immunosuppression. So this is to decrease the risk of the person rejecting the organ. So because the transplant recipient's immune system is manipulated. The target cells are the lymphocytes, macrophages, dendritic cells, and the monocytes. So the induction therapy is the first step in manipulating the recipient's immune system, and that happens in the OR. With monoclonal antibodies and steroids. And then maintenance, they need to use dosage that minimize side effects, prevent rejection, and allow a functioning immune system. They are long-term. It's a combination of 3 different medications, and there are side effects. Long-term side effects can occur. So some of the side effects can be helped by changing some of the doses. Other side effects could be malignancy because of the effects of the medication at a cellular level. Side effects can include anemia, bone disease, glucose intolerance, hyperlipidemia, hyperuricemia, hypertension, hyperkalemia, hypomagnesia, magnesemia, I always say that wrong, impaired wound healing, infection, malignancy, nausea, nephrotoxicity, neurotoxicity. Lots of things. Okay, if you have any questions, please see your professor, but I hope you have a wonderful week. Thank you.